Sometimes you have lenticular tags left behind. Sometimes you have some material coming in the way when you are fixing the contact glass. So just make sure that you are not having anything like this, because this can cause a big problem in separation. It's better to just leave it at that point and go ahead and refix again. Sometimes you have post-operatively fine interface haze in some cases. There is a role of potent steroids given for a short while in those cases. Persistent dry eyes can be because of the pre-existing dry eyes, so you have to treat it accordingly. And you should know that you still need to follow the rule of thicknesses, because SMILE, even though is potentially trying to keep the biomechanical strength less affected than LASIK, it's still going to affect because it's a subtraction procedure. So you cannot just treat form fristic keratoconus or frank keratoconus with SMILE thinking that it's not going to cause any weakening. And thank you very much. And thanks, Dr. Nitin and Dr. Pavitra, for this opportunity.
Thank you so I would like to call upon Dr. Chandrashekhar WAVIKAR sir. He is the Medical Director of WAVIKAR Eye Institute, Mumbai. He is the co-author of WAVIKAR Saurabh Toric tool and is one of the first users of lax surgery. Over to you, sir.
Thank you, Dr. Pavitra, for the introduction and also inviting me to give this talk. So, good morning, friends. I'm going to talk about wrong choice of procedure. While making a decision of which procedure to choose, many factors need to be considered. Traditionally, we have got a fixation on pachymetry, but pachymetry is not the only point which we need to see. So here is case number 1, 25-year-old female comes with for refractive surgery with a refractive error of around -2. Everything looks all right except that the minimum pachy is 474. And here we have to really see carefully that there is no ectasia or any sign of ectasia. Everything is absolutely normal. So the only treatment now we can afford to do is PRK, even though the PTA, if you calculate, it will be much less than 40. Because for such a thin cornea, we are on the border of getting ectasia, and therefore PRK is the way to go. Now, 31-year-old female, again, around -7.5 in the right eye and -9 with a small cylinder in the left eye, both eyes. Pachymetry is 578. The topo looks absolutely normal, including the posterior float. Same is with the other eye. Now, the most important, another consideration is pupil size. Luckily, in this case, the myopic pupil is quite small. And therefore, we can think of LASIK, because the PTA is 39 with an optical zone of 6.5 in the right eye and 5.5 in the left eye. Because the myopic pupil is 3.45 in the left eye, we can afford to do LASIK with an optical zone of 5.5. Of course, because the refractive error is high, option of ICL also needs to be discussed with the patient. Another case, -7, 25-year-old girl, male patient, -7 and 0.5 in both eyes. The pachymetry is 530, border, meaning on the lower side, slightly on the lower side for -7. And you can see, but the topo is otherwise absolutely normal. Then we go to the pupil, 5.91, and left eye it is 5.37. So for right eye, the PTA will be 41 with 6 millimeter optical zone, and therefore patient will have problem at night. OZ cannot be reduced to 5.5 because of the small myopic pupil, and therefore we have to think of LASIK. However, in the left eye with 5.5, we could just manage. So we have to consider right eye LASIK and left eye. Right eye ICL and left eye LASIK. So we can give different options for the treatment of different eyes. And it is better to discuss with the patients all the options and let him choose. 26-year-old girl with a with a minus 3.5, you should give us 2 more minutes because the audiovisual is giving a lot of problems. 26-year-old female with a refractive error of around minus 3 and minus 4 with a small cylinder. And look at the topo. There is definitely inferior stiffening in the right eye and also in the left eye. However, everything else is normal, so we can consider this as a case of FFKC. And therefore, the option given to the patient is topo-guided PRK plus C3R. Of course, we can also do PRK extra. Okay, all these options need to be considered with the patient. One is PRK extra in addition to PRK plus C3R, or just to observe and let the patient understand the risk of ectasia. And also because we are introducing some element of C3R, there is unpredictability about the refractive outcome. 22-year-old male with a small refractive error for Contura. So now we have a problem. Contura, the recommendation is that within the pupillary central 3 millimeter, the variability allowed between two topos is maximum is 0.75, but we try to be more strict, and most of the time we aim for minus 0.5 variability. Over here you can see that the variability is more, 0.87 and 0.76. So we have to counsel the patient that we cannot do Contura, but of course you can take chance, we can repeat Vario and see if you can get correct readings, and otherwise not, convert the patient to wavefront optimized treatment. Again, 20-year-old female coming for Contura, refractive error is small, but the cylinder is moderate. Now topo looks normal, but look at the cylinders now. As Dr. Nitin said in the lecture earlier, the difference between the two manifest and the topo refraction is the two cylinders is 15 degrees. Now let's see what happens when we add topo. The difference is increasing further. So there was a doubt in the mind whether we should do Contura or not, and first it is recommended converting the case to wavefront optimized. So even if the pupil, if you reduce the optical zone to 5.5 or 5, and the difference between the cylinder axis decreases, it is somewhat of a risk doing the Contura in this particular case. We can always take the patient back to the refraction room and check for axis, but most of the times there is hardly any difference, maybe 5 degrees. So we have to convert the patient to wavefront optimized. 38-year-old female, minus 10, minus 9, came for refractive surgery. Everything looks good. Topo. LASIK is the PTA is very high, and for ICL, the ACED is inadequate 2.64, and therefore, prelax, no, there is a very high risk of RD in high myopes, especially minus 10, and therefore consider CL as an option or leave the patient alone. On the contrary, here is a hypermetrope at the age of 38, and everything again appears to be quite normal, but rather than doing LASIK, better to consider prelax because the refractive error is going to keep on increasing with time. Of course, you have to check everything for multifocality. 32-year-old female comes with a refractive surgery, minus 24 in both eyes. Everything is normal, ACD is good, topo is also good. However, patient has retinal lesions. Now, many times with such a high refractive error, if the patient has lattice degeneration, anything you do with the eye, the peripheral retina opens like a zip, where there is a junction of the base of the vitreous and the rest of the vitreous body, and then it becomes very difficult to manage. So, such a high refractive error, I would not touch. Then, case number 10, you can see the cylinder is very high and the patient's visual acuity is not 6.6 BCVA. obviously there is something wrong. From refraction you can suspect, yes, there is a keratoconus, left eye, nothing. So obviously LASIK cannot be done and shifted to the management of keratoconus. Then there are some cases which are suspicious. Sometimes we suspect and sometimes the machine suspects. Now over the period we have realized that if either of them suspects, the chances of that patient progressing to keratoconus are definitely high, and therefore it is better to observe such patient. I have got 2 such cases. You can see that the right eye we feel is normal, but a machine says the classification is abnormal. Yeah. At left eye, there is a superior-inferior asymmetry. Therefore, best is not to do, best is to observe. Case number 12 is similar, so I can wind up.